Thanks, Tony, for the introduction. It's fantastic to be here tonight and see so many people coming along to hear about some fantastic ideas. I'd just like to start by acknowledging traditional custodians of the land in which we meet and Aboriginal elders past, present and those of the future. So my presentation is called Playing Hide and Seek, Why Does It Matter in Healthcare? And I want to start by kind of taking you back a bit in history and thinking about a group of former residents of this planet who maybe didn't really realise what the true risk factors they were confronting and thought the meteorite showers were their big problem, where in fact maybe it was some behaviours that they needed to pay attention to. And what I'm getting at here is that sometimes risk factors for disease, for things like heart disease and stroke, are not necessarily very exotic or very uncommon. They can be there in the background. There can be sometimes behaviours we don't really want to acknowledge, and sometimes they're not actually things we realise. You know, it may be that our blood pressure is not well controlled, or it may be that we're not eating that well, or maybe we're not physically active enough, and they're the things that may actually be the risks that will lead to illness and disability, and sometimes, unfortunately, to death. Currently, about 11 million Australians have one of the following 8 chronic conditions. It's arthritis, asthma, back pain, cancer, cardiovascular disease, chronic obstructive pulmonary disease, diabetes and mental health problems. Now, some of those are not preventable, but some of them are, particularly, of course, heart disease, cardiovascular disease, COPD, which is really about smoking, and also, to a large extent, diabetes. And chronic diseases are really kind of the major cause of disability, disease and death in the Australian community. They cause now 90% of all deaths, according to the Australian Institute of Health and Welfare. And they cost a lot in terms of health expenditure and also in visits to health professionals. But there's a problem, and one of the problems here, that's really what I want to talk about tonight, is that our healthcare services around the world are really organised, delivered and funded to provide a care for acute problems, for when you feel sick. When you've got a symptom, that's when people, understandably, go to see a doctor or other health professional or go to a hospital. And, you know, it's a bit like this cartoon. We could be going to the crisis clinic. The doctors and nurses and other health professionals could be busy putting out the fires of our symptoms, sometimes with increasingly high-tech and expensive treatments. But really, are we still heading for this, you know, over the cliff? Because maybe we haven't really got around to addressing the underlying problems with you know, long-term things which we need to deal with in a systematic, preventive way, and therefore we're still going to go get problems, even though we're doing a lot of work and it's costing a lot of money. Another problem here was realised by Julian Tudor Hart, who was a GP in the Welsh countryside, in some of those valleys in Wales. And he realised and published in the Lancet Medical Journal way back in the 1970s a thing called the inverse care law. And here he's pointing out that the people who most need healthcare, in his experience and in health systems, were probably the people who were least likely to come to get it. And that wasn't just due with cost of services, it was also due to sometimes with understanding of why you would need to seek out healthcare. Why does it matter if you hide away and, you know, maybe prefer not to go to see the doctor or the health professional? And also to do with other barriers. You know, it could be in rural and regional Australia, where a lot of our medical students from this university are trained and work. It's actually much harder to get to see a health service because they're less available. Or because you're an Indigenous person and the cultural barriers may be great, or because English isn't your first language. So there are a whole lot of reasons why the inverse care law applies, and it continues to apply in our healthcare system to this day. And we really haven't managed to really fully overcome this problem. And this indicates that, you know, it isn't just about providing equal services to everyone. I mean, everyone in this community here tonight probably has access to Medicare, and everyone can go to a high-quality public hospital if they're unwell and have an emergency problem. But if you actually want to get equity, where people have the same access to the fruits of a high-quality healthcare system and the benefits of that in a country, you actually need to provide different levels of support that targets the different need. And doing everything the same might be equal, but it doesn't actually produce equity. And that's an important point that really needs us to change the way we think about the delivery of healthcare services. Now, this is a slide from Kaiser Permanente, and Kaiser's a large health maintenance organisation mainly in the west coast of the United States, and they have about 15 million members. They have hospitals, they have primary healthcare centres, they have allied health services, they have an electronic medical record, and you think, wow, we always hear about the American healthcare system and how it's incredibly expensive and it gets poor outcomes, and that's true across the whole system. But like many things in the US, there are pockets of, very high quality amongst that very uneven approach. And what the Kaiser Pyramid points out here is that actually you need to think about different levels of involvement of healthcare professionals at different sort of levels of chronic disease. Most people with long-term illnesses, things like diabetes or arthritis or risk factors like hypertension or with asthma, can do a lot of their care for themselves. And in fact, they're the only people who can do that care. Only the person can choose what they eat or whether they exercise or whether they go to see a health professional or whether they take their medicines. The healthcare system can't do that for them. But where you get more complex disease and more comorbidities, things occurring together, that's where you need greater involvement of healthcare professionals, and you might need teams of healthcare professionals. It can't all be done by a doctor or all done by a nurse. Maybe you need input from an allied health person like a dietitian. Maybe you need advice on exercise from an exercise physiologist. Maybe you need to understand how to look after your joints from a physiotherapist. So you might need a team. And that's one of the things that Kaiser has talked about a lot. So also from the United States came a thing called the chronic care model. And this came from the McColl Institute in Seattle in the 1990s with Professor Egan Wagner and Tom Bodenheimer and others, thinking about, well, how do you organise the healthcare system to deliver more systematic, organised, proactive and forward-looking chronic disease care that isn't just reactive, but actually reaches out to people and provides good quality care and a healthcare system that supports that. And they talk about a number of different aspects of this, one of which is the idea of decision support to the healthcare professionals, where the healthcare professionals have evidence-based care, where they're doing what's known to work from the evidence and it's up to date, that you're using healthcare systems to identify those who are really in need, so you can search your records and invite people in proactively, that people are active participants in their own care, that they're exercising or eating well, self-management, and the community supports that. There's opportunities for physical activities, opportunities for healthy eating, all of those things, and that it's often a team that's involved, not only a doctor. And one of the sayings from Kaiser is, never ask a doctor to do what doesn't require a doctor. So don't get doctors' time doing things that really are better done by someone else, because medical time is expensive, and as I know, doctors are very bad at following protocols. They're really much better to get someone else to do that. So that was the chronic care model. Well, we set about applying these ideas to one of the most prevalent risk factors in the Australian population, and that's high blood pressure. More than 2 in 5 adult Australians have hypertension that is not well controlled. And we know that hypertension, there's lots of evidence about this, is a major risk factor for stroke and coronary heart disease. It's not a disease in itself, it's a risk factor. You don't have any symptoms if you've got high blood pressure. People sometimes think, I'll get headaches or I'll get blurry vision. That's usually not the case. Usually people, high blood pressure is totally, doesn't have any symptoms most of the time. But you can get, as I said, heart attacks, strokes, chronic heart failure, kidney disease, and those things can progress. And if you can reduce people's blood pressure, it greatly reduces the chances of those things. For instance, of stroke by about 40%, heart attack by about 25%, and heart failure by more than 50%. So treating blood pressure and keeping it under control definitely makes a difference. But we're not doing that very well at the moment, or as well as we'd like to. So what we came up with was a thing called the IMPRESS study, Improving Blood Pressure Control in General Practice. And what we did in this was we proactively searched the records of general practice clinics, and this was just in a pilot study in 8 practices in New South Wales, and we identified from that quite a lot of patients who were not controlled to target. We knew that their blood pressure was too high on their last visit, and we knew they had about at least a 15% chance of a heart attack or a stroke in the next 5 years. So they were high risk on the absolute risk assessment tool of a heart attack or a stroke. So we invited them in, and quite a few came along, not all, but quite a few did. And what we did was provided a series of visits with the practice nurse. We invited them in, we assessed their blood pressure and other cardiovascular risk factors. We provided some advice on things like lowering salt and exercise and all of those things. We agreed a plan of what they would do to address their blood pressure and other cardiovascular risk factors. We provided assistance over a series of visits with the nurse in a 6-month period and visits with the GP, and we arranged follow-up, as I said, with both the nurse and the doctor. And what did we find? Well, we found that actually at the 6-month follow-up, there was a mean drop of blood pressure of about 14 millimetres of mercury. That's like 3 blood pressure drugs, and also significant drops in body mass index, weight, and waist circumference. And that adherence to blood pressure measurement had improved, to blood pressure medications had improved. So it seemed to work, and we're very pleased with this, and we're ready now to take this idea out and test it in a randomised controlled trial here in this part of the world, and really see if this stands up when you compare it to a normal care control. And if it works in that sort of example of a high quality study, could it be applied to other diseases and to really try to address this burden that these hidden things, these hidden risk factors, which we may hide away from, but which are very important to our future and our health and staying happy and healthy in our own homes. So, thank you for your attention.